Here to start the third and final day off right is co-founder of Aspen Ideas Health and executive director of the Health, Medicine, and Society program at the Aspen Institute, Ruth Katz.
Hello, and welcome to the third and final day of Aspen Ideas Health 2021. I am Ruth Katz, co-founder of Aspen Ideas Health and executive director of the Health, Medicine, and Society program at the Aspen Institute. We're very excited about today's program, which will kick off in just a moment. But if we missed you for our first 2 days of programming, you can find all the videos, including, for example, conversations about medical research in space with Inspiration 4 mission participant Haley Arsenault and with Nobel Prize winner Jennifer Doudna on the Aspen Ideas Health website. We hope you enjoy it all. But we also hope that Aspen Ideas Health has inspired you to consider new ways of thinking, to share your insights with others, and to put your own ideas into action. That's what makes this event so special and so unique. As we close out our program today, I do want to take a moment to thank the many people and organizations that have made Aspen Ideas Health possible, including our incredible speakers, presenters, and interviewers who gave their time and their expertise to bring all kinds of important health challenges into sharp focus and to offer potential solutions. I think you would agree they have given us much to think about. A special shout out, of course, to our sponsors, both old and new, which even in these most difficult times have been great champions and supporters. Thank you as well to our media partner, NBC Universal News Group. They've been terrific to work with, and we especially appreciate their help in growing our digital audience. To the small but mighty Aspen Ideas Health and Festival teams and all the people who work tirelessly behind the scenes to bring this event to life, thank you, thank you, thank you. You are the best. And finally, and most importantly, a heartfelt thanks to every one of you for tuning in, for Zooming in over the past 3 days. Your enthusiasm for and feedback about the program has been most gratifying and most valuable. It will all help to make Aspen Ideas Health 2022 better than ever. We expect to be back on our beautiful campus in Aspen for that event, meeting in person, and hope to see you there. Until then, be well, stay safe. Let me now turn things over to your host for today's program, NBC's senior medical correspondent, Dr. John Torres.
Thank you, Ruth, and welcome back to the final day of Aspen Ideas Health 2021, presented by the Aspen Institute in partnership with NBC Universal News Group. Today's session looks at what lies ahead in finally containing the COVID-19 pandemic, the importance of building resilience in kids, and the strength it takes to overcome serious illness and rejoin the world of the healthy. We will also take our final deep dive, including audience Q&A at 4 p.m. Eastern. Join author and surgeon Atul Gawande and Chief Health Officer at Google Health, Karen DeSalvo, to discuss the future of medicine and healthcare in a post-COVID world. It promises to be a far-reaching and incredible conversation. But first up on the program today, Dr. Anthony Fauci, Director of the National Institute for Allergy and Infectious Diseases at the NIH. Dr. Fauci has become a household name during the pandemic and is considered the most trusted source for reliable health information for all things COVID-related. My colleague, NBC Nightly News anchor Lester Holt, sits down with Dr. Fauci to discuss the progress we've made and the challenges we still face in the fight against COVID-19. And as you'll see, we've invited some special guests to help me introduce Dr. Fauci.
Who is Dr. Fauci?
A guy on TV. He's a doctor. A doctor? A man? He is a doctor. He finds viruses. He's a person. And he's a motivational speaker. He gives vaccines. Because he still makes people better.
Hello, I'm Lester Holt, anchor and managing editor of NBC Nightly News, and this session is being streamed as part of NBC Universal News Group's partnership with Aspen Ideas Health. Today's session, from variants to vaccinations, an update on the pandemic with America's COVID-19 doctor, Dr. Fauci. I'm excited to welcome him here. It's great to see you. Thank you for taking the time for us.
Thank you very much, Lester. It's good to be with you.
I want to kind of back up and do an overview of where we are and where we're going. When this thing first happened, it was all about flattening the curve. We were all doing what we had to do to flatten the curve, and we talked about mitigation, and then came the vaccinations, obviously. And I think if you ask most Americans what their goal is, it's to be done with this, to be, done with COVID and get our lives back to normal. From a public health perspective, what do you see now as the realistic goals at this point?
Well, the realistic goal is to get enough people vaccinated so that you see a really rather sharp diminution in the viral dynamics. We're doing extremely well in the rollout of vaccines. I mean, if you look at the numbers, we have a third of the adult population is fully vaccinated. More than 50% of the adult population has received at least one dose. Importantly, when you look at seniors, about 80% or more of seniors greater than 65 years old have received at least one dose, and 65% of them are fully vaccinated. The results are obvious. The hospitalizations and deaths among the elderly group have gone down between 75 and 80%. That's the good news. The situation that's still challenging is that even with that, we still have not yet seen the kind of dip in daily infections. We've reached, we flattened the curve, Lester, but we flattened it at a level that's unacceptably high. We have a 7-day average of new infections of about 60,000 per day. We've got to get it remarkably below that. And I think we will be there because we are probably right at that turning point, that crossroads, where the people who are getting vaccinated, if you look at it sort of metaphorically as a race between the vaccine and the virus, which if left to its own devices will bounce back up, that as more and more people get vaccinated every day, 3 million people a day, given the amount that I just mentioned have already been vaccinated, we should start to see a sharp downward slope of that curve. And when we do, then we could start talking about gradually progressing more and more towards what we would like to see as normality, or as you said a moment ago, to get this over with. That's going to take months to do, but I think we're clearly on that pathway to do it.
The term we keep hearing is herd immunity. Are we overusing that phrase? Is that the technical goal?
Yeah. Lester, I believe that we've overused it because it is an elusive term right now, because we don't know exactly what that number is. Classically, the protection that you get in the community is a combination of the number of people that are vaccinated and the number of people who've been infected, recovered, and are protected against subsequent infection with the same pathogen. The reason why we have moving targets here are severalfold. One, we don't know what that magical number is. We know what it is for measles because we've had decades of experience with measles. But the moving target about this is that we don't know what the duration of the protection is from someone who maybe got infected 9 months ago or so. The other thing that's a wild card in this is variants, namely infections that are the same coronavirus with a mutation that makes it a little bit different, that may make a person who is either vaccinated or having been already infected not as well protected as you would have hoped. So all of these moving things make this elusive number of herd immunity really kind of difficult to define. However, the one thing we do know, putting aside this concept of herd immunity, is that the more people you get vaccinated, every single day about 3 million people get vaccinated, you get closer and closer to the control of the viral dynamics. That's absolutely certain. We may not know what that magical number is, but whatever it is, you're getting closer and closer to it as you get more and more people vaccinated.
On the good news front is we clearly seem to see that there's the real world evidence the vaccines is that they are working, and they're working in a very robust kind of a way. But we keep hearing we only know they're good for 6 months. I got my shots in March, so I'm looking at the fall, not knowing what my status is going to be. Are we going to get more clarity on that as to how long these shots last?
Yeah, we've got to be careful how people interpret that data. Let me explain. When you look 6 months out, you find out that you still have durability of immunity. So we know that it is at least 6 months. How far out, we don't know. I mean, you ask a very good question. Does that mean you need to get a boost in the fall? Not necessarily at all. It means we need to continue to follow people. And we know now what a correlative immunity is. There are certain laboratory tests that if they stay up at a high level and then start to slope down, we know when they go below a certain critical level, you become more susceptible upon exposure to getting infected. Right now, we know that's clearly firm until 6 months. We don't know whether it's going to be firm till a year or more. So we're preparing for the eventuality that we might need to boost people. And I think that's an entirely conceivable issue there, Lester. I do believe that sooner or later we likely will need a boost. When that will be, we don't know. But right now, we're preparing that we may need a boost, either because of the durability of the protection or if variants come up that make the vaccine efficacy a little bit less. And these are all things we're eminently preparing for.
There is, of course, the human nature part of all this, and we're beginning to see that in terms of that second dose. There's some evidence that a lot of people are not coming back for that second dose. Is that alarming, worrisome? How would you characterize that?
Well, it is of some concern. You'd like to see 100% of people. But if you look at the history of vaccines in which there are more than one dose, vaccines like the shingles vaccine, which require a couple of doses, or the hepatitis B vaccine, you find out that just human nature alone, there's going to be a certain proportion of people who are just for one reason or other not going to come back for the second dose. That's just part of human nature. It's about 8% now, I believe, for the SARS-CoV-2. That's even less than the percent that don't come back for the shingles vaccine. So what we need to do is make sure that it doesn't get any more than that, and by continuing to outreach to people to impress upon them how much better 2 doses is than 1 dose. And I think people need to understand that there really is a significant difference in the degree of protection with a second dose versus just the first dose.
There's been a lot made of vaccine hesitancy. In terms of what we're seeing, is it any different than what you would expect in what you were talking about in December when the vaccines first hit the market?
I think it's a little bit better, particularly, I believe, among the minority populations, Lester, because we've really put a considerable effort to get out there and get people at the community level to speak for the importance of getting vaccinated. And if you look at the percentage, particularly among African Americans and Hispanics who were hesitant to get vaccinated, that has gone down, the percentage of hesitancy. Unfortunately, there's a degree of hesitancy among others that is either at that level that we want to bring it down, but it isn't coming down. And that's the reason why we have a lot of effort going into what we call the COVID-19 community core, of calling upon trusted messengers in society. They could be sports figures, entertainment figures, and importantly, clergy, to get out and talk to people in the community and try and explain why it's important for their own health, for that of their family, and for that of the community to get vaccinated. So we got to keep pushing that envelope all the way.
And we talked a moment ago about the folks who are not getting that second shot, which brings us back to Johnson & Johnson, a single-dose vaccine. We know about the setback recently with those cases of blood clots. Do you think the fact, though, that it is a single shot, will that make people feel better? Or do you think we'll get past this negative news about that J&J vaccine?
Yeah, I mean, I think when you have a pause, there are going to be some people that I say, well, wait a minute, what's going on here? But what we need to, and I believe we've done it pretty well, is articulate that this was a exceptionally rare adverse event. And yet the CDC and the FDA called a temporary pause to more carefully examine the data and to alert physicians about what to do if you actually see someone that has this complication, to treat them appropriately. Now that it's been re-examined, it's been confirmed that it is an exceedingly rare adverse event. So now we're going to be back on track. This particular product is going to be now available for people. And yet, you're right, there are a lot of people who really feel they'd rather have a single-dose vaccine than a double-dose vaccine. So I believe we're going to start to see people getting back in line to receive J&J, just as people are enthusiastic about receiving the Moderna or the Pfizer product.
The CDC guidelines with reference to those who are fully vaccinated are still somewhat limiting, especially for folks who think, hey, I got these shots and I should be able to resume normal life. Do you see those restrictions being changed or lifted in some way in the coming weeks?
The answer is an absolute yes. We've already seen the CDC come out with guidelines of what people who are vaccinated can do within the home. You heard that a few weeks ago, that if you're with vaccinated people and even unvaccinated people in the setting of the home, you don't have to wear a mask. You can have physical contact. Grandma can hug her granddaughter, and grandpa can hug a grandson and all that sort of thing, which is good. We've also heard that it is much safer to be able to travel if you're vaccinated. Traveling in crowded places is still not recommended, but if you're vaccinated, the risk is remarkably lower. You're going to be hearing, little by little, coming out guidelines from the CDC about the kinds of restrictions that are being pulled back now that we have people who are vaccinated, because everybody wants to be free of the restrictions. And everyone has a degree, sometimes a high degree, of COVID-19 fatigue, and we want to get back to normality, and vaccine is going to get us there.
Yeah, we tend to look at this through an American lens, understandably, in terms of infections and hospitalizations and those sorts of things. And comparatively, the U.S. appears to be doing rather well compared to a lot of other countries, including countries in Western Europe. Can you speak about India and these other countries that are struggling and what effect that has on all of us?
That is such an important question. Lester, India is suffering terribly. You heard the announcement from Jake Sullivan, our national security advisor, about the things that we're immediately going to be sending over to India, everything from oxygen to medications to PPEs to a variety of things that they may need for the production of vaccines. All of that is now in play. The issue that's underlying all of this is that this is a global epidemic, and a global epidemic requires a global response. So not only for obvious humanitarian reasons and the moral obligations we have, since we're a rich country, but also there's a self-interest here, because you really want to get this virus controlled globally, because even if we will do a good job in getting our people vaccinated, as will the European Union and the UK and the developed nations, as long as there's a degree of viral dynamics anywhere in the world, there's always the threat of the emergence of variants from those places that might come back and obviate some of the things that we've done to protect ourselves. So we need to do it because we're a rich, generous nation that have extended ourselves historically. Look at what we did with HIV and the PEPFAR program in the developing nations. It's a historic demonstration of the generosity and the humanity of the American people. I think we can do the same sort of thing with SARS-CoV-2.
And you expressed a worry earlier about the number of daily infections, not not down to where you think it should be. In terms of restrictions being lifted in many states and many communities, is there any chance of unringing that bell, or to the extent that things are being loosened up, have we missed the opportunity to tighten them up again if necessary?
Yeah, what's going to happen is that if you start seeing surges in places, you may have to retighten things. That's the reason why you've heard me say so many times, and I'm very sensitive to the people's needs to be free of these restrictions, that you don't want to declare victory prematurely, because if you pull back too early before you get enough people vaccinated, you're going to start seeing the kinds of things that we've seen in several states, where you've seen resurgences of infections at a time when you really want to keep it under control. Again, the race is on, and every single day, the vaccine part of the race takes a step in the right direction by getting 3 million or so people vaccinated every day.
I want to ask you about therapeutics in a moment, but first, we're at 3 vaccines right now. Do you anticipate or see any other vaccines down the pike here that might be introduced into the system?
Oh, absolutely. Domestically and certainly globally. Well, we have AZ, which is now still being looked at, will soon, I hope, put forward their package to the FDA to get an emergency use authorization. We have Novavax, which is a different vaccine platform whose data in other countries looked at actually rather encouraging. I think that's going to be in play. We have another company, Sanofi, that's making another vaccine platform. So it's more than just the 3, Lester. There are candidates that are now in play, getting ready to get enough data to be able to apply for an emergency use authorization.
And how are we looking in terms of vaccines for kids? I know Pfizer was in a trial for 12 to 15-year-olds. Do we see that coming down the pike soon?
Oh, yes, absolutely. So the Pfizer trial in the 12 to 15-year-olds looks really good. I mean, it was like virtually 100% protection in the adolescents. So by the time we get to the fall term, I believe we'll be able to vaccinate high school students, which is really going to be an important step forward. With regard to younger children, we already have studies that are ongoing, which are called age de-escalation, which means that you want to make sure, since children are so vulnerable, and you want to make sure that you're giving them a product that you feel confident is safe and effective in the children. So you take children from 12 to 9, see if that's okay. Then you go from 9 to 6, from 6 to 2, and then 6 months to 2 years. So by the time we get to the end of this calendar year and the beginning of the first quarter of 2022, I believe we'll have enough information to be able to vaccinate children of any age.
I want to ask you about therapeutics. We haven't heard much about treatments in hospitals for those who are infected with COVID. What can you tell us about the progress of keeping people alive who end up in serious condition in hospitals?
Well, we've made some considerable progress in just the skill in taking care of people when you get enough experience. But also there have been some products approved by the FDA and others that have emergency use authorization. What we really do need now is a utilization early on of, for example, the monoclonal antibody combinations that are being underutilized because they require logistically intravenous administration. We've got to get that down to a sub-Q administration, give it to people early enough to keep them out of the hospital. The intermediate and longer range approach is to do targeted drug development of direct antivirals, very similar to the huge successes that we've had with antiretroviral drugs for HIV, which have really transformed the lives of HIV-infected individuals, and the transformation of the cure of hepatitis C. That was all done by targeted antiviral development. We have a couple of candidates that are right now early on in trial, looking encouraging, but the big investment and the big commitment is going to be to target the vulnerable part of the replication cycle of the virus so that we will have, when we get a very, very low level of infection, that we'll have drugs that when someone comes in with symptoms, we could give them a drug that's orally administered, that will not require them being in the hospital, but that will prevent them from requiring to go to the hospital. That, to my mind, is the goal of therapeutics.
And is there a recognition that COVID is going to be with us, if even on a low level, and that we'll need those kinds of medicines, going forward?
I believe so, Lester, because when you have infectious diseases of this type, there are three possibilities. You can eradicate, you can eliminate, or you can control. I don't think there's a chance we're going to eradicate this. We've only in history eradicated one human virus, and that's smallpox. You can eliminate it in certain countries, the way we've done with polio here in the United States, the way we've done, for example, with measles, because we have very good herd immunity in measles. I think we're going to get very good control of it for a while. It may take a couple of years to really get it out of the picture, but I believe we're going to get it within this year, low enough to be able to really make some good strides towards normality. But as you're suggesting, there very well might be a low level in the community that's not threatening in the sense of a public health hazard, but individuals could be threatened by it, particularly susceptible individuals. And for those individuals, those are the ones you want to make sure when they do get infected, you have a therapy for them to prevent them from getting serious disease.
And lastly, I want to ask you about those who have already been infected and their antibodies. Do we know more about what protection those naturally produced antibodies are offering, and whether that would qualify or help us get on this road to herd immunity?
Well, great question. In general, when you are infected with a virus, you develop an immune response that for variable periods of time protect you. If you got infected with measles, the way I did as a child, because it was before the measles vaccine, you're essentially protected for life. That doesn't appear to be the case with coronaviruses, so it's not going to be an indefinite protection. The one thing that's really interesting, Lester, that we found out, that usually natural infection induces a protection that's better than anything else you can do. But we're finding out that the vaccines are so good that they're inducing a level of protection that's even better than the protection that's induced by natural infection, which is really good news for vaccines.
Well, thank you for a terrific conversation, Dr. Fauci. Always appreciate hearing from you, and thank you for your work and that of all your colleagues on trying to get us through this and out of this. So we do appreciate it all.
Same here, Lester. Thank you for having me.
The pandemic has created a dangerous new normal of delaying preventative care. Kim Keck, CEO of Blue Cross Blue Shield Association, and Julie Rovner, Chief Washington Correspondent at Kaiser Health News, discuss the importance of getting back on track and how to make that happen.
Welcome, I'm Julie Rovner. I'm so happy to be here with Kim Keck. Before we get into it, Kim, why don't you give us the 30,000-foot view of what we're about to talk about?
Sure, Julie, it's great to be with you. So during the height of the COVID-19 pandemic, we know millions of people stayed home to flatten the curve, as we called it, right? And in doing so, they put off screenings, checkups, vaccinations, and elective surgeries. And more than 3/4 of adults who delayed care had one or more chronic condition. Also, we know many of those are populations of color, so postponing care could worsen race-based disparities in health. So I think now's the time to ask, what does this mean for the long-term health of Americans and for the future of our healthcare system?
As you mentioned, everybody knows somebody who has delayed or gone without care during the pandemic. I am personally overdue for several medical visits. But what do we really know and not know about how much care has been missed and what the consequences of all that missed care might be?
We know that care was avoided for both prevention and for treating chronic conditions. And more specifically, we know that about 1 in 3 Americans delayed or skipped medical care during the pandemic. And I think I read something like 2/3 of patients said COVID-19 affected their ability to manage their chronic condition. And many of those said that as a result, their condition worsened over the course of the pandemic. Something else we know, the CDC reports that there's increased prevalence of care avoidance from Blacks and Hispanics relative to whites, so this could exacerbate what we already know is true in health disparities. And then on the prevention side, we know from our own data at Blue Cross and Blue Shield that immunizations for things like whooping cough, measles, polio are down 25%. So just even think about that last statement, right? These are treatments, these are prevention techniques that really could, once they're missed, put people at the greater risk for contracting both preventable and very contagious diseases. So back to your critical question, Julie, about what are the consequences? We don't completely know, as I said, but there are certainly a lot of us studying this issue. One of the anecdotes we've heard, and some evidence, but not significant, is some cancer care specialists really worrying about advanced or severe diagnosis that could have been caught earlier from routine screening. I think we're going to know more soon on those kinds of issues. But here's two other things we know. More to do with the delivery system than potentially health of patients. But when we look at the COVID-19 pandemic and we compare it to something like the SARS epidemic almost 20 years ago, one of the things we could see is surge in hospitalizations for chronic care conditions that might have been for care that was not taken care of during the pandemic. We also could see higher demand for provider visits, creating some stress on the system because there could be backlogs for all of us to get back to that routine care that we put off. So a lot to learn, but those would be some observations.
So as you mentioned, the pandemic has shined a bright and not all that attractive light on the way our health system underserves so many populations. Will the pandemic-induced postponement of care worsen those race-based disparities in health, even as policymakers and those in the healthcare system are redoubling efforts to reduce them?
Yeah, I mean, it has, right? I mean, I think one of the things we know from COVID-19, and we saw very early on, is the disparities that really COVID-19 exposed and in many respects exacerbated, right? Some of the statistics that we all have read so much about and are still seeing as we progress through this pandemic is that Black Americans are dying at rates that are something like 1.5 times greater from COVID than white Americans. And Native Americans, that rate is something like 2 times white Americans. Having said that, we also know, Julie, you well know, disparities are not new, right? We see them in a host of other health conditions. We know that Black women, in fact, are 3 times more likely to die from pregnancy-related complications than white women. And it's incredible. It's just unacceptable. We also know Black Americans have the highest death rate and the shortest survival of any ethnic group, racial group for most cancers. And recently, we know the CDC considered or suggested or declared race and racism is a serious threat to public health. So here's the thing. I think we're at a time and a place in our country's history where we are going to see significant action. This is a complex set of issues. It's not one-dimensional. There's not a one-dimensional solution. But Blue Cross and Blue Shield is one example. Our companies have articulated a national health strategy. We're focused on many aspects of this national equity issue, right? So first and foremost, I'll give you a couple of ideas of what's in our national equity strategy. It's advocating for industry standards with respect to collecting data, race, ethnicity, language data. And under the old adage, you cannot manage what you cannot measure. So certainly we need to do better on the basics, but we also need to do things like targeted interventions for chronic conditions that plague communities of color, like maternal health. And in fact, we recently announced that maternal health will be our first focus of our national health equity strategy, with a goal to reduce disparities in maternal health by 50% within 5 years. There's an awful lot of components to it. This is about incenting performance, closing gaps in cares, training providers and members, thinking about basic issues like unconscious bias training and the like, and really some of the underlying root causes of inequities.
I feel like this pandemic has highlighted all of the weaknesses of our healthcare system at the same time. One particular problem that we've had here in the U.S. that many other countries have not had is our continued reliance on fee-for-service care. When there's no service provided, there's no fee, as many providers found out the hard way in 2020. Might the pandemic hasten the transition to other forms of payment?
I certainly hope so. I hope that this crisis provides an opportunity to do exactly that, right? We know that the pandemic exposed serious shortcomings of our health ecosystem. Certainly the public health system wasn't prepared. But as you suggest, the pandemic exposed this antiquated way that we pay for healthcare in the United States, where doctors and hospitals are paid for each and every service they provide, right? And that last year we found out early in the pandemic anyway, really put the health care delivery system at financial risk. Exactly as you suggest, I say that all the time, Julie, right? When people weren't able to seek medical services because of shutdowns, there were no services. And as you suggest, when there were no services, there were no fees. And doctors felt this pretty pronouncedly right from the start, right? Many smaller independent practices have suggested that they may close or consolidate with larger practices because of the financial strain when many of us skipped routine healthcare in 2020. I think it's something like close to 60% of physicians said COVID-19 would lead to a reduction in the number of independent practices in their communities. And before the pandemic, we had a shortage because there was something like 80 million people, Americans living in areas of the country that already had a shortage in primary care professionals. So we certainly have to address this weakness. And I believe it's got to be a fix for the next healthcare system we create.
So is there anything that we've learned this year that helps to provide a roadmap for helping fix the system, particularly the way the pieces of the system work together, or more accurately, don't work together?
Yeah, I think what we were just talking about with respect to the antiquated way we pay for services, it does a couple of things, right? It puts the financial system of the delivery system, if you will, at risk. But it also makes it really difficult to be a patient. And I believe we have to take an opportunity out of this crisis to really advance what we call these innovative models that we've been talking about for many, many years. Models, I believe, that start with primary care, that provide incentives to coordinate care, to get quality care at the right setting, right time, and can deliver better costs over time. I do think, as we talked about a moment ago, the models that existed like that during 2020 really fared much better than our fee-for-service payment models, if you will, particularly when these kinds of coordinated care models were paid on budgets or even what's called capitation. They had better outcomes and at least better stability in how they could manage the populations that they served. And certainly the other aspect we haven't really talked about, but certainly 2020 was a catalyst for, I'll call it telehealth. And I know telehealth, someone smarter than I said, telehealth is not digital health, and I agree. So the pandemic, though, I think gave us the beginnings of what could be digital connected care. So I'm optimistic that these models can work. And I hope that we use this opportunity to make a more accelerated shift away from fee-for-service to budget-based models that are based on primary care and really incent the right kind of coordinated care with the right kind of outcomes.
Kim Kat, thank you very much.
Thank you, Julie.
We have a very special guest joining our next speakers, Dr. Ashish Jha, Dean of Brown University School of Public Health, and Jeanette Bettencourt, Sesame Workshop's Senior Vice President of Social Impact. They are in conversation about the challenges families have faced over the past year and how to build resilience in children. You might want to have your young kids tune in for this discussion.
Hi everyone, I'm Dr. Ashish Jha, Dean of the School of Public Health at Brown University, and I'm so pleased to be here at Aspen Ideas Health to hear about how big thinkers are talking about health today. And big thinkers don't have to be famous doctors. They can be regular parents, like my friend Louie, Elmo's dad. Hi Louie, you seem like you're in a good mood.
Well, hi there, Doctor. It's nice to see you, and I am feeling especially excited. I'm happy because I got my COVID-19 vaccine.
That's terrific. I was so happy when I got mine too. But let me ask you, how did you talk to Elmo about it? It can be a pretty complex topic for children to understand, and Elmo is young.
Well, yeah, that's right. Elmo is 3.5. So, yeah, we talked about how a lot of grown-ups are getting the vaccine to help us get back to doing some of our favorite things that we've missed. Elmo was excited to think about the two of us going back to Hooper's store to share cookies with Cookie Monster. And he was super happy when we talked about him being able to hug his Nana again.
I know what you mean. Kids have missed out on so much this past year. Of course, getting the vaccine doesn't mean the pandemic is over, and we still have to be careful and follow health and safety guidelines. But you're right. It will be great to do some of the things we've all been missing. And the vaccines are going to help us get there. I'm glad you were able to help your son understand.
Oh, thanks, Doc. Oh, Elmo and I even made a little video about it. Oh, take a look.
Okay, Daddy, Dr. Elmo says you're healthy.
Oh, well, thank you. Our children and families want us to be healthy. That's why I and lots of other grown-ups got the COVID-19 vaccine, so we can stay healthy and get back to the moments we miss, like seeing our friends and family.
Here you go, Daddy, for a healthy checkup, a sticker.
Oh, thanks, son.
With free COVID-19 vaccines, sunnier days are ahead. Visit getvaccineanswers.org.
That really helps people understand, and that's what I call big thinking.
Oh, well, thank you. Oh, now I'd like to introduce you to a friend who helps me understand so much about being the best parent to Elmo that I can be. Her name is Dr. Jeanette Bettencourt. I'll leave you guys to chat.
Thanks, Louie, and take care. And hello, Dr. Bettencourt. Dr. Bettencourt, families, as you know, have been struggling. Kids have been struggling, and I'd love to hear more about how we're all working together to help people get through this difficult time.
Thank you so much, Dr. Jha. It's such a pleasure, and I'm so glad that you had your conversation with Louie. We've been doing quite a bit, and as you said, we're in that period of time of transitions. Sesame Workshop, the minute the pandemic started, we started addressing ways that we can actually explain what COVID was and the impact and what staying in place or shelter meant. But then what we've been doing, and I think now we're putting this in the context of sunnier days ahead, it's how the vaccine, how our continued practices around safety, around COVID, will help us as families to move forward. And all of these resources that we have are freely available on sesamestreet.org/caring. And we find that having resources that help explain, particularly for young children, these multiple transitions, and also how to cope with the changes that are coming.
Dr. Bettencourt, I would love to hear how you're maybe helping kids and adults adjust to what I think will be maybe some hard days getting back. If you haven't seen your friends in a long time, you haven't seen some family members in a long time, it may be hard to see them again for the first time, maybe after a year and a half.
Absolutely. One of the wonderful things that we do is we use these wonderful Muppets to actually show the kind of questions. So Elmo actually asked about how it is going back to school. He's a little nervous about taking that on because suddenly he's been home for a long time and now he has to go back to his routines. He's also doesn't know what to do once he gets there. So we have all these resources that are helping explain from a child's perspective how to make those transitions. But also, I think it's the idea that you pointed out, Dr. Jha, and that is that idea of continually asking questions for our children. Sometimes because they're young, they show us rather than tell us. And so they may show that they may be a little more clingier, or they may show that suddenly they're not paying attention. So asking them as many questions as we can about how they're feeling, and also preparing them for that next stage of transition early before it happens. Then I think going back to our theme, we both will have sunnier days ahead, even in our households.
Absolutely, absolutely. And vaccines are amazing, as you know, Dr. Bettencourt, that they have been so important in keeping kids healthy, preventing all sorts of sicknesses, of diseases. And the COVID vaccines are just one more in a series of these wonderful vaccines that keep people healthy, prevent them from getting sick. And so once these vaccines become widely available to everyone, they'll really make a very big difference.
I agree. Thank you so much, Dr. Jha, for this conversation, but most importantly, highlighting that idea of sunnier days ahead.
And Dr. Bettencourt, thank you for everything Sesame Workshop has done to help kids and families get through what's been such a hard year. The good news is things are getting better. And also thank you to Louie for bringing us together here. I had such a nice time talking to you, so thank you very much.
For a different perspective on the pandemic, we'll now hear from some of our youngest audience members about the coronavirus, vaccines, and what they're most looking forward to when the pandemic is over. Kids do say the darndest things.
No. That's a man too. Coronavirus is a virus. A deadly disease. It's a sickness that can be really bad. You can't see it, but it can spread. It's a kind of germ. A coronavirus is a disease, or as we call it, a virus, and most people hate it. Stay inside. It's something where you have to wear masks. A pandemic is something where you're locked in a house. A pandemic is where people are on lockdown and they have to stay in their house, which people also hate. A vaccine is something that will make you not catch the coronavirus or any other virus. It's when you get a shot. Yeah, it's that thing you load in the shot and then you put in a human and then they can't get it. A vaccine makes you safe for COVID. Like if you got 2, you wouldn't get COVID. If you got 1, if you only needed 1, you wouldn't get COVID. It's to vacuum.
It's to vacuum?
Yeah.
Oh, okay. Do you like to vacuum?
Yeah, sometimes. I don't know. It looks like a ball with tons of sticks coming out of it. It's like a ball in the middle and it has little things coming out of it. A germ. A disgusting, gross germ. Kind of like Brussels sprouts. To keep each other safe. To not get it. To keep you safe. Because it's safe. To keep our faces healthy. I don't know. Go to Hawaii. Go outside in the pool and stay in the pool and hotels forever. Go to the store without mask.
Go to the store without a mask?
Yeah. I'm looking forward to doing yoga. Like a crescent, like a big crescent, like a moon.
Like a moon?
Yeah. As healthy and happy. Just go out with my friends and have fun. Not inside.
Aspen Ideas Health is generously supported by Abbott, Blue Cross Blue Shield Association, the CDC Foundation, Cedars-Sinai, the Commonwealth Fund, Johnson & Johnson, Merck, Mount Sinai Health System, and Pfizer.
And now we have a conversation about the need to create a healthy, sustainable, and accessible food system with chef and author Bryant Terry.
Hello, everyone. I'm Joe Yonan, and I am very excited to be here with Bryant Terry, who is chef, author, food justice advocate, activist, gardener, father, husband. You can stop me at any time. Bryant's work is something that I've appreciated for many years, so I'm excited to talk to him today. And we're talking about sustainability and sustainable food systems. And I thought I would first, really, Bryant, just ask you for your definition of a sustainable food system. What does it actually entail?
You know, Joe, when I hear that question, my mind immediately goes to what I argue should be the primary function of a sustainable food system, and that's feeding people, feeding everyone. And we know that we produce enough food globally to feed about 10 billion people. So theoretically, there shouldn't be any hunger or food insecurity. But as you know, there are nearly 800 million people who suffer from hunger and food insecurity. And I think it's important that we determine, what are the deficiencies and gaps in our food system that's creating this reality and really working to correct them. Um, you know, Once again, this may not come as a surprise to you, Joe, but it's really heartbreaking to me that the people who are most impacted by hunger and food security are the people who are actually growing our food. The Food and Agriculture Organization tells us that 80% of the world's chronically hungry are actually farmers. If we were to just look at what's happening domestically, I will offer two things. One, the subsidies that are often going to big ag and that ensure that, they can produce, when we think about the food that's actually contributing to the decline in public health in the United States, these are mostly foods that come from the big ag that's subsidized, and they're able to produce foods that are artificially cheap. So the food that are high in fat, high in salt, high in sugar, low in the desirable nutrients that we all need. So what if we reverse that? What if we ensure that the mid and small size farmers who are growing food with integrity, who are growing it with an eye on sustainability, who are growing food with a real deep concern for all systems, for ensuring that people are fed, for ensuring that we have healthy soil. What if we ensure that those farmers got the supports that they need? So I'd love to see that, and I think that we need to decentralize a lot of the farming here in the U.S. from rural areas and think about how can we create more infrastructure for urban agriculture. So a lot of
Right. I mean, a big part of sustainability is economic sustainability, right? So, whatever system we have has to be profitable enough, I guess, to be sustainable for the future. How does that affect your thinking about sustainability?
When you talked about economic sustainability, the first thing that comes to mind, Joe, is something that I'm often underscoring in my presentations and really encouraging people to understand that we can't just look at food issues in a vacuum. We know that lack of access to good food is simply one indicator of material deprivation in these communities. Most often, these communities also have crumbling infrastructure. They have underfunded, segregated public schools. They have very little green space for people to be active. There are very few jobs, and the jobs that are available oftentimes don't pay a living wage. And so we need to look at all the ways in which these historically marginalized communities have been impacted and thinking about addressing all those issues. We can have as many supermarkets and urban farms and all these types of resources for accessing healthy, fresh, and affordable and culturally appropriate food. But if people can't make a living wage to pay to take care of their families, if they can't have green space that they feel safe to be physically active in, if there aren't schools that are going to educate their children and prepare them for the 21st century, then what are we doing? So I always encourage people who are thinking about food to also keep one eye on these larger issues that are also connected to food insecurity.
Great. One of the things that I'm sure a lot of our listeners will pick up on what you said is you dropped a phrase in there several times that I think is very important and that I want to circle back to, which is culturally appropriate. So in a lot of conversations about local food and sustainable food, you don't necessarily hear people talk about the importance of culturally appropriate food. And I have a sense that you probably have a lot more to say about that. So I'm curious kind of what you mean by that and some examples of maybe ways in which food hasn't been so culturally appropriate, especially when it comes to this movement, the movement for sustainability.
Let's just think about the reality that so often when people talk about plant-based eating, vegetarian, vegan, there are these kind of stereotypes or ways in which people immediately go to, upper middle class suburbanites or hipsters living in gentrified urban centers. And these are typically the faces of white folks, right? And what that does is it erases the history I mean, if we just want to talk about traditional diets, whether in West and Central Africa or throughout many parts of Sub-Saharan Africa, or different parts of Asia, or even traditional diets here in the Americas, we know that many of these diets are largely vegetable based, right? Even if meat was a part of the overall diet, oftentimes it was used for seasoning, to add flavor, to add a little fat. When people had large quantities of meat, it's often on holidays and special occasions and celebrations. We know that before the industrialization of our food system, having meat at every single meal was cost prohibitive for most working class and working poor people. And so there's a precedent. Like we don't have to put fancy names on the diet, but there are ways in which people, the communities that I would argue have been most impacted by, our runaway food system, negatively impacted by runaway food system or food insecurity. These are communities that have these traditions of eating healthfully, whether you're talking about, African Americans, or we can look at Native Americans. So if we don't talk about these diets in the context of colonialism and an industrialized food system, then we're missing the larger point that pre-industrial food, pre-colonialism, these were largely healthful diets. And I think that's one of the reasons that when we're talking about, the criteria for an overall healthful diet, we hear a lot about nutrients and micronutrients, but I always argue we should talk about, well, what are the foods that our ancestors ate? What were our great-grandparents and their parents eating? Because these are the foods that have sustained us for generations. And so when we talk about food, sustainability, plant-based eating, vegetable-forward eating, however you want to talk about it, I think it's important that we highlight these traditions that many other communities that are suffering from some of the highest rates of preventable diet-related illnesses, like hypertension and heart disease and type 2 diabetes. We highlight these traditions so that people feel like they can embrace something that is theirs, that's culturally relevant, and that actually moves them towards better overall health and well-being.
Well, let's talk about your book work a little bit, Bryant. You bring your own diet and culture and heritage together in the cookbooks that you've written, but you're taking a little bit of a turn in your career, and I wanted to give you a chance to talk about that a little bit. I believe you even referred to it as retiring from writing cookbooks. So I want to hear more about that and let our audience hear more about that. What are you working on? You're finishing up a massive project now whose title and cover is reflected in the chalk drawing behind you, I believe, right?
Yeah, Black Food is my forthcoming collection of stories, art, and recipes that I am curating and editing. And the book is actually going to be published by my new publishing imprint, which is called 4 Color Books, which is a publishing imprint of Penguin Random House and 10 Speed Press. And so informally, throughout my writing career, I've always, made myself available to younger writers and done all I can to support them in, publishing work and getting it out to the world. So really this imprint is just kind of a formalized way of me now having more resources and power to work with authors and creatives that I like and respect and ensure that their work can be seen widely as well. So, we acquired our first book and we're building the list from here, and I'm really excited about what we'll be bringing to the world in the coming years.
It's so exciting. Congratulations. When I first heard the news, as you know, I was ecstatic. So, so what are you, when it comes to Black Food, the book, what are you hoping to accomplish with the book?
As you know, so much of my work has been pushing back against a lot of the kind of reductive ways in which people think about, talk about, write about African-American cuisine, largely reducing it to the antebellum survival foods that many enslaved Africans relied upon, or the kind of big flavored meats that you might find in soul food restaurants, the big flavored meats, the overcooked vegetables, and the sugary desserts. And I'm not denying that these aren't part of this larger, more complex and diverse cuisine. But what I argue is that so often what we don't talk about enough are the healthful origins of it. We talk about like the type of dark leafy greens like collards and mustards and turnips and kale and dandelions and sugar snap peas and pole beans and all these type of foods that I think any allopathic Western trained physician or dietitian or nutritionist would say that we should all be eating. And so, you can't talk about African American cuisine without talking about the larger foodways of the global African diaspora, the food from West and Central Africa, from which many enslaved Africans came, to the Caribbean, to the American South. I mean, we need to talk about Native American foods, European foods. So, I always argue that African American cuisine is the original modern global fusion cuisine. And, coming off the work that I do at the museum, thinking about the body of work that I've built as a cookbook author, all that really just coalesced beautifully with this new book project, which is largely inspired by my residency at MOAD. Literally, many of the chapters are literally taken from programming, and that's a chapter of the book. Black Women, Food, and Power, which was the first program that I had at the museum, which brought together some scholars and farmers and food justice activists to have a conversation about the historical and contemporary roles of Black women in the production and distribution and consumption of food and food knowledge. And so, all these things are my attempt to help us to see the connections between this larger global diasporic community. And just, the main thing for this book, Joe, for me is I wanted to move past just being mired in the problems. We know that we have a broken food system. We know that this broken food system has had such a negative impact on the health and the environment and the spirit of communities throughout this country. But the kind of guiding quote for me throughout putting this book together was Toni Morrison's charge. What do our lives look like without racism? When we don't have to be when Black folks aren't so consumed with the albatross of white supremacy and racism on our neck, what do our lives look like? We're, in touch with our agency and our magic and our brilliance. And that was what I explained to every single person who contributed to this book. So this book is about beauty. It's about joy. It's about our brilliance and agency. And it's one of those books that I hope seamlessly moves from, the kitchen where people are making recipes to their bedside where they're reading the stories at night, to their coffee table or their credenza so that they can look at the beautiful art and just really consume all the goodness in this book. So I can't wait for you to see it, and I can't wait for the world to have it.
Yeah, oh, ditto. I can't wait to see it. Oh, it sounds like it's going to be just beautiful. Well, since we're talking about beauty and joy and maybe the future a little bit, I wanted to ask you a little bit about kids. I know you're a father. I've recently started foster parenting, which has been really exciting and challenging. I may call you about that later. But I'm curious if you have thoughts about how important it is to engage kids in the goals of healthy eating and even sustainability.
20 years ago, I started my entree into food activism was working with young people when I started this organization in New York City called Be Healthy, Build Healthy Eating and Lifestyles to Help Youth. And so from the beginning, I've been very clear that if we want to have a successful food movement, we need to invest in young people. When I think about many of the social movements throughout the 20th century, whether it's the anti-apartheid movement in South Africa or the civil rights movement here in the American South, it was young people, their bravery, their brilliance, their just ability to just be out in the streets fighting for what's right. That's what we need to invest in. And so, I think about that on a larger structural kind of approach, but I also think about it just on a personal level in my home with, my wife and me and the way that we raise our children, our daughters. And, there are a couple things that we've done to help invest in them cultivating a love for healthful eating and even being these kind of budding food activists. I think with parents who are hoping to, get their kids in the kitchen and getting them invested in eating healthfully or just eating good food, I think getting them involved in the kitchen, preparing and cooking food as early as possible is an approach that you should try. It was something we did with our oldest daughter when she was 3 years old and probably a little younger than that. We would, have her going to, the farmer's market with us, obviously shopping. And so she got a chance to meet the farmers and see the local producers who are actually growing the food that we're eating regularly. We have several raised bed gardens at our home where we're growing food. We had our daughter, as much as she could at such a young age, just being involved in the planting and the watering and the harvesting and the tending, all that stuff. But then in the kitchen, when she was 3, we literally started to get her involved in helping us prepare food. So we would harvest some food from the garden, and we'd set up her 3 little buckets. One would be with the say dark, the collard greens. The next one would be a bucket of water where she could clean them off. And then the third one would have a bucket and a colander where she could just let them sit. And as she started to, grow and her developmental capacities increased, then we got her more involved in the kitchen. And now as a 10-year-old, she's making full meals. Joe, she made her own birthday cake. She made a vegan chocolate cake with balsamic roasted strawberries and chocolate ganache. No help.
What? That is the dream. That's the dream. Yeah.
We see food as one of the primary tools to teach our girls about who they are, their history, their culture, the taste and, classic ingredients and, dishes. And so food is just everything. I mean, maybe that's just kind of, I'm stating the obvious here, but food is our life largely revolves around food here at the Terry Coon household.
Yep. Well, that's great. Well, Bryant, I want to thank you so much for this conversation. It's been delightful to connect with you and to hear about your work and to hear your thoughts on sustainability. And thank you very much.
Thank you, Joe. Been a pleasure.
And now let's take a mindful moment. The COVID pandemic, as experienced in this country, has made clear what we have long known but have done little to address. Racism is a public health issue. Indeed, CDC Director Dr. Rochelle Walensky has recently declared racism a serious public health threat. Up next, Johnson & Johnson Executive Vice President of Global Corporate Affairs, Michael Sneed, talks with CNN's Lisa Ling about racial inequities at the front lines of care and how to address them.
Hello, everyone. I'm Lisa Ling, and I'm thrilled to be here today to host an important conversation for Aspen Ideas Health around health inequities with someone I've just loved getting to know. He is so smart, so kind, and so cool. He is Johnson & Johnson's Chief Communications Officer, Michael Sneed. Michael, so great to see you.
Well, great to see you again, Lisa. I hope you're doing well.
I am doing well. Now, over the past year, during the COVID-19 pandemic, we know it has just disproportionately impacted so many marginalized communities in our country. So what lessons on health equity do you think the American healthcare system should be pulling from during this unique moment in American history and world history?
Yeah, there's certainly a lot of lessons. And, one of the things that I think we saw early on was the disproportionate impact to communities of color. And I think it's really been a centuries-old problem that's kind of reared its head within the pandemic. And certainly it's impacted marginalized communities, frankly, in ways probably people never really imagined or never really took the time to think about. But clearly what we've found today is that your skin color really is a risk factor when it comes to whether or not you're going to suffer from COVID-19. And I think one of the key lessons learned for me is that we need to have a much more sophisticated, much more culturally competent way of engaging with and treating Black and brown patients.
Now, I want to talk about the corporate role in all of this. Over the past few months, many corporations are making commitments to help end racism and health inequities in the U.S. So can you tell us about J&J's commitment through your recently announced Our Race to Health Equity commitment? And why does Johnson & Johnson feel compelled to take on something as massive as racial injustices as a threat to public health?
We all did some real soul searching, including the people here at Johnson & Johnson, to figure out what should be our role really in advancing the cause of racial and social justice. And then we kind of stepped back and said, look, we're the world's largest healthcare company. And with that goes a tremendous amount of responsibility. And so we started to talk. We listened to a lot of our people. We listened to experts. And then ultimately we said, look, we have to figure out a way to join in and to take action. And so with the support of our CEO, Alex Gorski, we really convened a number of leaders across Johnson & Johnson and really challenged them to figure out what can J&J do in the world in which we know, right? We know healthcare, but this is a problem that's well beyond healthcare. And clearly it's a problem that's gone on for centuries and centuries. But I think looking at our credo, looking at our purpose, it really said to us, now is a time where you've got these two challenges that are happening. You've got the challenge of the pandemic, that's raging. And frankly, you've got the challenge of systemic racism. And the impact of that is really having a profound negative consequences for people of color. And so out of that came our initiative called Our Race to Health Equity. And it really was around how do we eradicate racial and social injustice as a public health threat. So it's a very bold kind of question, and we figured we needed to have bold statements and actions that went along to answer that. So it was really around three specific pillars, if you will. The first is really around what we call our people first culture. And that is about always looking inside first, making sure that we've got our own house in order, so to speak. And so we made a big commitment of increasing the number of Blacks and African Americans at the manager level or above by 50% over the next 5 years. The second pillar is really focused, and the next two pillars are really focused externally. First is around healthier communities, recognizing that J&J really does understand health, but we also know that when it comes to these communities of color, that there are specific actions we can take as an organization to really advance the health of all communities. And that starts with things like making sure that we can train healthcare professionals in culturally competent care, as an example. It means there are ways for us to increase the pipeline of people of color who are going to go into the healthcare field. So that, again, people who are in these communities, they're going to see healthcare workers and more healthcare workers who not only look like them, but understand the particular situations that they're in. The third area within healthy communities is around diversity in clinical trials. One of the best ways that we can change the outcome of individuals within communities is to get them into clinical trials so that promising new treatments when it comes to cardiovascular disease or diabetes or any other chronic condition, to make sure that we are developing the best solutions for people of color in addition to the main population. And then the third area is what we call enduring partnerships. So when it comes to things like financial literacy and getting access to capital, education, healthy food, these are all things that really do make a difference when it comes to the health of communities. We play a small role of that, but being a coalition partner with our size and our scale, we think we can accelerate those efforts.
We know that communities of color have been so disproportionately affected by COVID, but what are some of the other injustices that Black people and others in communities of color currently experience in the healthcare system, and how has that changed over the years?
At a very simple level, Lisa, if I could say this, if you're a black child born in America today, you have a shorter average life expectancy than white children. So that's about as simple as you can make it. Throughout your life, if you're a black person, you're much more likely to be living in fair or poor health. That's just a matter of fact. It's also very true when it comes to maternal mortality, where again, if you're a black woman, you're more than 3 times as likely to experience pregnancy issues and death, frankly, than white women. So these are things that are, in many ways, really unconscionable when you sit here in the time we are in our history, and to realize that we have, we still are dealing with these great disparities.
Let's talk about healthcare workers. You talked about the importance of diversifying this demographic. So what role can healthcare workers, particularly nurses, midwives, and community healthcare workers, play to begin eliminating inequity and injustice in the healthcare system?
Well, I think we all know that when it comes to the healthcare system, it's those frontline healthcare workers that really do make all the difference. Anyone who experiences any type of health challenges, that nurse, that healthcare worker, midwife, they're the ones that really make the system run. And frankly, they're the ones that probably honestly are the ones that really impact you as an individual more than anybody else. And so we know they play a significant role, a huge role in having the opportunity to really eliminate inequity and injustice within the healthcare system. And likewise, I think as Blacks and African Americans in these communities really understand how much you have people like healthcare workers who are on their side, who are invested in their outcome, as they start to see that gel, I do think you'll see real progress. But make no mistake about it, this commitment around healthcare workers has to continue. It's one of the things that we've done at Johnson & Johnson with our initiatives over the last several years, particularly with what we call the Center for Health Worker Innovation, where again we've pledged about $300 million over the next 5 years to really make sure that we can bring this to a reality and that we can continue to serve as many communities of color around the world as possible.
Michael, in what ways do you hope that this can stand as a model for other companies and institutions to replicate?
Well, Lisa, our hope really is that every company is taking a look at their purpose, and they're really asking themselves, what can we do to dismantle systemic racism? I'm very proud of what Johnson & Johnson is doing, but I know we're just one company, and something like this takes a major coalition of companies and institutions. And it's one thing to say Black Lives Matter, but that if systemic racism continues to exist, it really becomes destructive to our healthcare, and frankly, it becomes destructive to the very lives that we care about. So I hope that corporations really do take the opportunity to say, how can they be part of a bigger effort? It clearly takes a village, but I hope we'll all come together to make an impact.
Well, Michael Sneed, thank you so much for taking the time to talk to us. And I really applaud you and J&J for really taking the lead on this. So thank you so much for taking the time, and thank you everyone for watching today.
Thanks, Lisa.
Up next, a heartfelt discussion about the journey from illness to recovery and ultimately to health. Suleika Jawad and Kate Bowler, both authors and cancer survivors, talk about the self-discovery that occurs during the transition from sickness to health.
Hi there, my name is Kate Bowler, and I'm here with my absolutely delightful, beautiful friend, Suleika. Suleika, I would have this conversation with you anywhere, any place, and I'm just so glad that we get to do it now.
Oh, me too. The feeling is so mutual. As I was saying earlier, I'm just sad we're not in Aspen, but we can pretend we're in Aspen.
Absolutely. Truly. We have such a strange kind of commonality, which is that we've both dealt with cancer in an ongoing way at a very early age. And after reading your completely stunning book, Between Two Kingdoms, I thought maybe we might have a little conversation about some of the lessons I kind of drew from your book about true hard things that are true about having cancer at a young age, which might also be true for people who are thinking about how to manage and endure their sort of life after pandemic. The second anyone gets to know your story, one of the hard true things that pops up right away is nobody told me that I would lose so much, maybe so soon. You had a very precipitous decline / experience. I wonder if you wouldn't mind just starting us there.
Yeah, I mean, as a culture, we're so steeped in the cult of positivity. You know, we're told to search for the silver lining, to stay positive, to stay strong. And I think when I first got diagnosed with leukemia at age 22, I was determined to remain the same person I'd been. I thought I was just going to have a short sojourn in the kingdom of the sick and that I wouldn't need to unpack my bags. And I resisted that label of cancer patient and was determined to keep pursuing the same things I'd been pursuing, you know, after graduation. But of course, that didn't happen. Pretty immediately, I started to count those losses. And there were so many of them that happened so quickly that it left me kind of reeling and breathless. There was the loss of my identity as I'd known it. There was the loss of my hair during chemo, which was like the first outward symbol and confirmation of what I knew but hadn't fully felt real yet. There were the loss of friends who I'd expected to be there and who didn't show up. There was the loss of infertility. More than anything, I felt the loss of time, I think. This sense that the future was limitless no longer rang true to me. My days felt numbered, and there was a sense of urgency that came with that.
Yeah, that was maybe one of the strange little bits of, I wonder if you felt this too at the beginning of the pandemic, things that kind of felt like it was, I don't know, like if somebody rings like a crystal glass and then it starts to like ring other things in the room, but like something that rang from cancer for me through the pandemic was like the feeling of being robbed. Like I had time and now you're taking it from me, just kind of being squeezed into a life that is like not listening to what I need and what I love and who I am and what I need to do.
Yeah, totally. I think there's a way in which when we're in the midst of a reckoning, no matter what that reckoning is, we get pinned to the present. The past no longer feels applicable, and if anything, it reminds us of what's no longer possible, and the future's full of uncertainty and fear. And there's a kind of narrowing of your vision when you're made to be present in that way. That can be really alarming and uncomfortable because we have to see what's directly in front of us, and we have to confront ourselves.
It's so funny. I'm such like a kind of, I mean, I won't say sweet. No one calls themselves sweet, but sort of just like an easygoing person. But like when you're describing that with such gorgeous precision-filled language, I feel like a surge of rage. Like I'm like, oh my gosh, someone's taking my time. Like I think you're exactly right. We have to renegotiate. We're getting pinned to the present. What a perfect phrase. It makes me feel like claustrophobic, just even you describing it.
Totally. And I think, there's also a centering, clarifying power that comes with that at least for me, felt necessary. There was a way in which all the kind of artifice and anything that felt superficial just could no longer exist in that present. And I saw things really clearly. Probably, I think I saw things more clearly than I ever have in my life. And, I think that's one of the strange things about being on the other side of this experience is I sometimes miss that sense of clarity. I try to imagine now what I would do or what would feel important if I felt that sense of time being limited, because I think it's a useful exercise for all of us. But especially when you're young, right? We feel immortal. We feel like we have time to get to the things we want to do. And of course, that's true and not true for all of us, no matter how old we are.
Yeah. Oh, I love every word of that. There was a crystalline beauty to things that helped me know what to love, and better than I ever have before. And you're right, maybe better than I ever have since. So I really resonate with what you're saying. I wonder too, when I was thinking about your story, another true hard thing was that maybe no one ever told me how guilty I would feel being hemmed in, having a crisis. I know that it was a lot. It's just, you imagine that if you're the primary sufferer, that guilt is not a primary emotion. But when you're suddenly the center of everyone's orbit, I imagine it like reorders all of your relationships in a way you would not have chosen.
It's such an important observation, and I think one we don't talk about enough. I mean, grief for me was my constant companion throughout all 4 years. And I know that my mom and my family and friends would have been sad to hear me say that. I felt guilty because of the amount of resources I was taking up. I felt guilty that my mom had put aside her career because she needed to be my primary caregiver. And even though it was a labor of love, I was very cognizant of the fact that it was a whole lot of labor. I felt guilty about the financial strain that the situation was placing on my parents and my brother, who was my bone marrow donor and who felt such tremendous pressure because in his mind, and he was, a senior in college at the time, if my bone marrow transplant failed, it was going to be his fault. And it wasn't a rational thought, but all of it was rational. The guilt wasn't necessarily rational. And I think that's what makes it so hard to talk about things like guilt. Because if we do dare to kind of give voice to it, then the immediate reaction often is, oh no, you shouldn't feel that. And of course we know that too. But it's one of those things, I think, very much like shame, that kind of festers and multiplies until you kind of bring it up to the sunlight.
Mm-hmm. Mm-hmm. It's, and as people who are trying to see things clearly, trying to love the right things, trying to make the right evaluations, I think it's such a fair emotion when we're just noticing with our eyes and with our ears that there is an economy of scarcity just because we're all human and there's only so much money and only so much resources and only so much, daylight. And it reminds me of some of the exhaustion I'm hearing from, first responders or parents or people who are like, am I allowed to break down? Am I allowed to feel tired? Am I allowed to not want to be a primary caregiver a year into an earth plague? But guilt, I'm sure guilt feels like the response when you know that it's limited and there might not be enough.
Yeah, and I think it's also somehow tied to not feeling a sense of agency, and therefore not fully understanding why certain things were what I could possibly do about them, and then just swimming in this lagoon of guilt. I felt guilty about my diagnosis. I would kind of time travel and wonder, was it that cigarette I smoked in college? Was it all those all-nighters? Was it, I don't know, with sugar and the caffeine? And, you try to locate a reason. And even if you do find a reason, of course, that doesn't mean that you're any more deserving of whatever diagnosis or whatever difficult thing has happened to you.
Yeah, which totally, explains people's rush to, and this is the third thing I guess I wanted to reflect about your book is is the feeling like maybe no one ever told me how strange it would be to live in the after, like not yet fully healed, like not fully sick and not fully well kind of life feeling. What I always think of is like in my mind, I'm always thinking like life is a chronic condition, you know, and I get kind of like, I find that like the ongoingness of that. And I find that part of remember at the beginning of the pandemic, that rush where everyone's like, oh my gosh, I'm finally going to use those free weights in the gym. Like I'm going to there a rush to hyper agency, a rush to, sounds to you like that's another response to feeling hemmed in and then not being sure how to re-enter a world that's remade.
I'd spent 4 years dreaming of being on the other side of this, of kind of finding myself back in the kingdom of the well. But that didn't happen. Instead, I was kind of suspended in this liminal space where, like, on paper, it was over. But off paper, I couldn't have felt further from being, like, the healthy, happy 26-year-old I hoped to be on the other side of all that. I was carrying the wreckage of this experience. I was having almost a kind of reverse culture shock. I had no real clue of what the path forward was for me, of who I really was. I knew I wasn't the same person I'd been before my diagnosis and that I couldn't return to being that person. But the future felt completely blank in a way that was frightening. And I think it's something that we're all living right now as we begin to like tentatively do certain things that many of us haven't done for the last year. I just got on my first plane in a year, and it was like I felt like I'd forgotten how to pack and forgotten how to speak to humans outside of my corn pod. And I think all of us, are going to be forever changed by this pandemic. And the question for me is, what parts of this experience need to be left behind? What parts of it I want to carry forward with me? And how this strange time of being kind of suspended, and how having to kind of step away from the culture of busyness, like how all of that is going to inform what we do next.
Yes. Because and that was like the fourth kind of thing I was thinking about is the no one ever told me when I'm allowed to stop being afraid. But that is, you're right, is the challenge of moving forward, is which parts of this time of intense restriction do we, I just find fear to be such an unusual companion for making choices. Because usually fear has helped me figure out what I love with a really bright clarity. But then, but you have to let the miasma of all of the rest of it go, which feels like really tough math. So, especially when we've had such a prolonged amount of learning to be afraid of everything, just trying to step out into a strange, different kind of courage, I guess.
Yeah. And, I think when the ceiling caves in on you, either because of a diagnosis or, we've all had that experience collectively, globally in the last year, you no longer assume structural stability, and you have to kind of learn to live along fault lines. And that's difficult, right? It means living with a sense of uncertainty and possibility also. And it's also, I think, a heightened awareness of what the Grain Jodidian describes about how life can change in an ordinary instant. And I think there's a way in which, at least for me, that fear, it always feels like I'm either, it's either threatening to hijack my entire day, or it's the thing that's going to ignite me to do the things that I know are important.
Totally. You're right. You're right. For me, it's either the darkness or the flashlight, and I can't figure out which which one it is.
I love that. The darkness or the flashlight. That's the perfect image for it.
Suleika, you are wise and kind, and the way you use categories with such grace to help us all, it just continues to inspire me. So thanks so much for having this conversation with me. This was beautiful.
Kate, thank you. And I hope the next time we do this, I get to interview you because I could fangirl for many hours about your brilliant mind and your brilliant books and all the incredible work you're doing. It's an honor.
This was awesome.
Up next is a conversation about the importance of access and affordability in healthcare with Abbott's Executive Vice President of Rapid and Molecular Diagnostics, Andrea Weiner, and Peggy Clark, Executive Director of the Aspen Global Innovators Group at the Aspen Institute.
Hi, I'm Peggy Clark with Aspen Ideas Health, and I'm delighted to be here with Andrea Weiner. Andrea is really on the front lines of Abbott's COVID response, and I'm delighted to have this opportunity to talk with you, Andrea.
Thank you, Peggy. It's a pleasure to be here with you and with Aspen. Thank you.
Great, wonderful. So, you're really sitting at such a critical frontline position in the COVID response. Before we get into some of the details, I wanted to just have a sense of, can you share with me a few thoughts of how you think the pandemic is really impacting healthcare over the long term?
Yes, thank you, Peggy. At Abbott, we're a global healthcare company bringing life-saving technologies to people around the world. And over the last year, you're right, we've been known for our role in fighting the pandemic. And, maybe I think of the world as COVID and pre-COVID. And so if we talk about pre-COVID, we were looking at trends in healthcare. We were watching trends in healthcare where patient care was moving in acute situations from the emergency room to urgent care, into retail, and then at home. And with these trends moving, that's when we made the investment to bring testing to those alternative care models. And then the world comes in with COVID, and we saw that trend accelerate. We saw, those trends picking up pace because it's about increasing access. We need to get more people tested when they need it and where they need it more. And then when we bring in COVID, not only did we accelerate those trends, but we saw new places of care come, even more alternative care settings. How has testing evolved? I would say it's accelerated. Moving into these non-traditional channels and then bringing even new channels to care delivery. And consumers get used to the convenience. If we think about at the beginning of the pandemic, to get tested, people were waiting in long lines and the test results were taking days to come back. And where we're at now that we've been able to bring more supply into the marketplace, people are expecting, that they don't have to wait in lines, and they're also expecting that they get their result on the spot. And that is going to be a trend that sticks.
I really appreciate that, Andrea. And you've talked a lot about these two pivot points of access and affordability and alternative delivery centers. But tell us a little bit specifically about what you were involved in and sort of take us back to the moment when the need for testing escalated so dramatically. What was the response of Abbott, some of the innovations that you were involved in, and some of the challenges that you faced in rolling these out?
The first part is developing a test, but also developing a test is only half of it. It's about the scale and the capacity. And we've never seen anything like this where the world was needing tests. Typically, when we have an outbreak, it's a country, it's a certain part of a population affected. This is the world needing tests all at the same time. So with each of these tests, we activated our manufacturing capacity. We expanded capacity. We built new plants. To date, we've launched 14 tests. We've distributed over 400 million tests in 2020 alone. And this took, hundreds of millions of dollars building 2 brand new plants. And also just to put this into perspective in numbers, in 2019, we had distributed 18 million flu tests. Compare that to 400 million COVID tests between March and the end of the year when we didn't even plan for it at the beginning of the
But
year.
Andrea, let's say, most of the viewers and me included and everyone else, the testing was a real challenge. So how did you and how did Abbott respond to that? And what were some of the barriers that you faced that meant that most of us had a really challenging time, and still the access to tests are not what we would want them to be?
Whatever was challenged before COVID certainly broke and became very challenged during COVID. Where the system was weak, it became weaker. Where we had inequities, those inequities widened. That's why we're particularly excited about where we are now in our newest launch into COVID testing. And that is very much focused on increasing access and affordability. So we've just, we are launching right now our Binax Now over-the-counter test. That's a rapid test that we can produce in the millions at a much more affordable price and get it into retailers around the country so that we can increase the access and we can increase the frequency of testing to slow the transmission and get to those underserved populations. What we know is that everyone has been challenged by the pandemic, but we know not everyone equally, right? We know certain populations, particularly populations, communities of color, Indian reservations, you name it, many underserved populations have been hit hardest. So this is, the Binax Now is really a great tool for us to get into the communities that haven't had access to testing. Additionally, what we're able to do, with this test is also, in many cases, it's about getting it onto retail shelves so we can just increase the volume of testing. What we've also done to make places safe, for gathering is provide an ability for an authenticated pass. This is a digital pass. So as we bring this testing into certain environments, such as schools or universities, where we really want to make sure communities are safe, we can provide that additional complementary app.
So how far is that from coming to market?
We're rolling out our, the Binax Now over-the-counter test. It's going to be at retailers across the country. The retailers are going to be stocking the Binax Now across all of their stores because the focus of not only Abbott, but of our partners is to make sure we're getting to all, populations and increasing access. So it's about making sure that we have the intention of getting this test everywhere that there's a retail clinic. And then, if that's not enough, we'll continue to work with organizations to get to unpenetrated areas.
So what do you see in your role? You've been with Abbott for quite some time. How is this going to change the way you do your work?
Being on the front line at Abbott and seeing the need for closing the gap, with the inequities that we're seeing has really led us to lean forward more, right, in terms of access and affordability. We've recently put out some pretty bold aspiration targets for ourselves based on this and based on the experience that we've had over the last year to increase access and affordability. So what we've done is we've put an ambitious goal out there. Today, we touch 2 billion people with our technologies across the globe. And what we've said is by the end of the decade, we want to touch 3 billion. We want to touch 1 in 3 people in the planet. And that's a bold goal, but it takes us doing things differently. And it takes us starting in our development process to design products that can be done at a more cost-effective price, to design products that can work in many different type of environments and aren't so dependent on high technology. So again, we're doing this in our development process. We've done this with Binax Now, where we can show that we can bring a product at a very affordable price at scale. We've also done this with our Freestyle Libre, which is a continuous glucose monitoring device for those with diabetes. We started very early in that process to make sure we had access affordability in mind, and we were able to price that at about 70% less than other continuous glucose monitors and work with governments to get that product reimbursed. So these are, examples of what we're doing in our R&D, in our operations, And now we're going to be making sure this is in our design process.
So even in this moment of huge challenge, we see these possibilities opening up. Andrea, it's just been fascinating to talk with you. And I really appreciate that you sound so hopeful. And I think we'll all be thinking about this conversation when we pick the rapid test off the shelf at our local pharmacy and are thinking about all the hard work behind that. It's really been a delight to talk with you, Andrea, and thank you for all that you have done in this critical moment that's affected so many families.
Thank you, Peggy.
We next welcome to the Aspen virtual stage Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization, who has a special message for the Aspen Ideas Health audience about the global health challenges of the pandemic and beyond.
Excellencies, dear colleagues and friends, it's an honor to address such a distinguished gathering. While we have made great strides in our collective fight against the COVID-19 pandemic, it's far from over. Intense transmission is ongoing and is putting enormous pressure on hospitals, intensive care units, and health workers around the world. We now have the tools to bring this pandemic under control, but tools are only as good as the people using them. While we have developed vaccines, therapeutics, and diagnostics in record time, they're still not getting to many of the countries and communities that need them the most. The decisions made by leaders now will determine how quickly we can end the acute phase of this pandemic and the massive disruptions to lives and livelihoods. As well as leading the global public health response to COVID-19, WHO continues to manage a large number of other emergencies, including Ebola in Guinea, and providing medical support in fragile states, including Syria. We're also working with countries on a global treaty on pandemic preparedness and response, an idea that has been endorsed by 25 world leaders and counting. And we continue to work all over the world to strengthen health systems and to support countries to make progress toward this universal health coverage. The United States has been a long-standing friend and partner to WHO, and we welcome the Biden administration's commitment to global health, multilateralism, and to our shared work building a healthier, safer, fairer world. I thank you.
Thank you, Dr. Tedros, for that message. Thank you for being part of the Aspen Ideas Health, presented by the Aspen Institute in partnership with NBC Universal News Group. We miss seeing you in person and so appreciate you joining us during this difficult time. We hope you have found the program stimulating, even enlightening, and that conversations begun here will continue. For all of us, it's been an incredible 3 days of exploring and learning, though we're not finished yet. Please join us for the final deep dive session of Aspen Ideas Health at 4 p.m. Eastern. Most experts agree that the pandemic will have long-lasting effects on our healthcare delivery system, and that in many respects, that system will not return to normal. Remember, no registration is required to join these live sessions. Just check your email for the links and follow the directions on your screen. Thank you again for joining us. And don't forget, mark your calendars now for Aspen Ideas Health 2022, June 22 through 25, when we hope to see you all in person on our campus back in Aspen, Colorado. Until then, be well and stay safe.
Thank you, Dr. Torres. The Aspen Institute provides thought-provoking and groundbreaking discussions week after week and has since 1949. Those ideas belong in the minds of curious and engaged people around the world, but we need your support to get them there. Please consider donating to help us develop, execute, and share innovative ideas like the ones you've heard today. From all of us at the Aspen Institute, Have a happy, healthy rest of your day. All the best.